Good afternoon, everyone. I'm Tudao, one of the co-chair of the AI. I'm sorry. Good, okay. Good afternoon, everyone. My name is Tudao, one of the co-chair of the Iaslc Asian Conference on Lung Cancer. Thank you for attending and watching our first ever press briefing focused on research that is specific to patients and clinicians in Asia who are coping the thoracic malignancy. In addition to an excellent lineup, the researcher today section including a new element for the first time. We have invited section discussion to share additional element perspective on the prison study and the impact on the clinical patient across the region. Please hold your question until the end of section, and the brief is being recorded and video file will be available shortly after event. Before getting started, I would like to introduce my fellow co-chair who will be also moderating with briefing. Professor Wendy Cooper, Professor Feng Kong, and Dr. Yaomi Suzuki. Now, I would like to invite Dr. Yaomi Suzuki.
Okay, hi, my name is Ayumi Suzuki. I'm a thoracic surgeon from Japan, and I will introduce our first presenter, Dr. from Korea.
Hi, My name is Myung-Ju An from Samsung Medical Center, Seoul, Korea. I'm a medical oncologist. I presented the current landscape of future perspective of EGFR targeted therapy. As you know, the EGFR mutation is a prototype of the precision medicine in non-small cell lung cancer. Actually, the incidence of EGFR mutation is very high in Asian, around 50 to 60%, which is a huge burden. So I think so it is very valuable to review this current landscape. So the EGFR mutation was discovered back in 2004. During the past 20 years, a lot of effort has been made, and the treatment landscape is continuously evolving. So we have a first generation, second generation, third generation EGFR TKI, the first line therapy, and also olotinib plus beva, or the gefitinib plus chemotherapy was approved as a first line. But recently, the osimertinib plus chemotherapy and the amivantamab plus amivantamab is also approved in first line. The development of the EGFR TKI is focused on the high CNS activity and prolongation of PFS and overcome the resistance, the heterogeneity. So currently we have three options: OC mono, OC plus chemo, or amivantamab or lazertinib. So all these, the data suggested that the survival of the OC mono is 38.5 months, and the OC plus chemo, the 48.7 months, and the amivantamab lazertinib is not reached yet. So that, but the different of the resistance, the action of the drug, the side effects is different. So, for example, the OC plus chemotherapy, the most common adverse event, the hematologic toxicity. In contrast, the ME plus the lazertinib, the EGFR and MET related toxicity like skin rash, paronychia, the diarrhea, and the immune infusion reaction, and peripheral edema is most common. So how to choose these agents is one of the questions. But I think not only the efficacy, but also the side effect and the patient preference and the cost and the drug availability is the main issue to choose both one of the effective drug. And the other one is who is the appropriate for the monotherapy, because the monotherapy is still recommended as a first-line therapy. So, so based on this study, two studies, the patient as a tumor-related factors, the patient who has no high-risk factors like ctDNA negative, T53 commutation negative, no liver or brain mets. Those patients, and the ctDNA negative, those patients might consider it for monotherapy. And also the patient-related factor, the patient with poor performance, poor organ function, the comorbidity, or the financial issue or quality of life, those patients is considered the monotherapy. So all these factors should take into account which kind of the first-line treatment in EGFR mutant non-small cell lung cancer. And unfortunately, all the patients develop resistance when they give mono or combination. We strongly recommend the repeat or tissue biopsy to understand the genomic alteration or other resistant mechanism, or sometimes a histologic transformation. And the treatment options for the biomarker-driven treatment is include the fourth generation EGFR TKI against the C797S, or the combination of TKI plus MET inhibitor, such as MET TKI or antibody-drug conjugate in patient with the c-MET amplification or MET overexpression, or combination of the other targeted agent based on the genomic alterations. For those patients without the biomarker-driven, we can give the all-comers approach, such as the Mariposa 2 regimen, the amivantamab plus chemotherapy plus minus lenvatinib, which is approved in the FDA. The other approaches include the antibody-drug conjugate or chemotherapy plus minus osimertinib, or the chemotherapy with anti-angiogenic plus immunotherapy. So all these options are available, and we have to choose the one of them based on the efficacy, toxicity, and the patient preference. So, so I think still there is a lot of room for improvement in the first-line therapy. So recently, the antibody-drug conjugate combination with the EGFR TKI in first-line therapy, the several ongoing trials are underway, and also EGFR TKI failure combination or the single agent, the ADC, after patient who failed the EGFR TKI is also ongoing. So those studies will elucidate the role of the ADC in EGFR mutant non-small cell lung cancer. In summary, especially in Asian the countries, the incidence of the EGFR mutation is very high. I think we should be very cautious to choose one of the three options. And also the other the issue is the drug availability and accessibility. So there is a lot of a gap. So we should improve the global equity in the lung cancer care. So that's my summary of my presentation. Thank you for your attention.
Thank you so much, Dr. Ahn, a leading expert on EGFR mutated lung cancer in Asia. And as you pointed out, Asia is the region in the world with the highest prevalence of EGFR mutated lung cancer, and is where many of the pivotal trials for EGFR targeted therapies have taken place. So thank you very much for your insights. I'll now invite Dr. Zheng Zhenseng from Taichung Veterans General Hospital in Taiwan to tell us about some of the oral abstract presentations that we heard about.
Thank you. I'm Jason Zheng from Taichung Veterans General Hospital, Taiwan, and I'm a pulmonologist. I'm pleased to be here and participate in the ACLC 2025 and to discuss on this interesting studies. And my discussion yesterday involves two parts. The first one is regarding the management of early stage lung cancer, including the prognostic value of the fertility index and the PET metabolic parameters for early stage lung cancer, and the role of microwave ablation for patients with higher ground gas capacities. Nowadays, that we have many weapons to fight with early stage lung cancer. However, we know that many patients still experiences the disease relapse after complete resection of the tumor. So it's important to identify the biomarkers or good prognostic prediction models to guide the adjuvant treatments for these patients to reduce the recurrence rate and improve their outcome. And here I also want to highlight the data reported by the Dr. Liu, which show the data regarding the role of microwave ablation versus lobectomy for patients with a higher ground gas capacity. It's important, particularly for the patients in Eastern Asia countries, because we know that many patients may have recurrent tumor or with synchronous multiple primary tumors. and they cannot reset that many lungs because of limitation of the lung function. So the data show that the microablations for hydrogen gas capacity associated with lower complication rate and better lung function reserve, and the relapse-free survival comparable between patients treated with microablation and lobectomy. So we need more data to apply to these procedures in our clinical practice in the future. And the learning curve and the reimbursement criteria also important before clinical application. But for patients with multiple primary tumors, it may be an attractive options for these patients. And the second part of my discussion is regarding the lung cancer screening, including the application of artificial intelligence via CheckSFIM for lung cancer screening and the cost effectiveness of population-based lung cancer screening in Vietnam. We know that as compared with the treatment of the stage 4 disease, many studies show that lung cancer screening may be a more cost-effective option because the treatment of stage 4 disease will result in high economic burden for our government. So a better screening process or project will help us to early diagnosis of lung cancer and improve the nationwide lung cancer outcomes. So it's very important, and the data reported in Vietnam also show that it's a cost-effective options to prescribe lung cancer screening. And for the middle to low that income countries, maybe that's artificial intelligence plus CheckSFIM is alternative options, but we need the more data to confirm its usefulness and the cost effectiveness in clinical practice. So in my opinion, the management of lung cancer through the screening to treatment and follow-up should be a continuous, comprehensive and collaborative plans. And I'm pleased to discuss on this data which address different aspects of this process, including the lung cancer screening, the cost effectiveness issue, the role of artificial intelligence, and the local ablation therapy strategy, and also studies try to identify clinical prognostic factors. But as I mentioned, more data and more evidence are still required before clinical application. But I'm happy that all the data reported here to provide us very informative insights for future investigations. And I'm also looking forward to that more data that can help us to establish a better treatment algorithm and to improve the outcome of our patients in the near future. Thank you.
Thank you very much for that. That's really fascinating to hear about the artificial intelligence and how that may assist in screening of patients for lung cancer. What we're going to do now is have a few words from each of the conveners of the meeting who tell us about why they think the Asian Conference on Lung Cancer is so valuable and give some insights into an area of interest to them. So I'll pass over to my co-chair, Dr. Ayumi Suzuki, who will give you some further insights. Thank you.
Okay, thank you, Wendy. IASLC has been emphasizing the importance of having a women in thoracic oncology session through its years. And so we had one this morning at the ACLC 25. And Asia is still developing mentor-mentee relationships, and it's important to let the early career physicians, the difference in the, is a strength, and bringing diversity is essential in a society. And Asian doctors tend to be more shy than the rest of the world, and that was part of the discussion. But we had a lot of insights from the rest of the world to inspire the young era. So we had some important insights from different diversities, and one tip was we heard was that we don't have to have a one-and-on relationships, but we can seek for lots of mentors in their own specialties, and you could have mentors and supporters in many aspects of your career. And we hope to provide these sessions in future conferences too, because we just couldn't get through all of the questions we were expecting. So please look forward to our future sessions. Thank you.
Thank you so much. And I think the International Association for the Study on Lung Cancer has always been very strong supporters of equity and diversity, and have always supported women in thoracic medicine. So I agree, it was a great session. To me, I was really honoured to be one of the conveners for the Asian Conference on Lung Cancer 2025. IASLC is the international organisation that's leading in our knowledge on lung cancer and education, teaching, and any advancements. But and it has the benefit of being multidisciplinary. So it's surgeons, it's respiratory physicians, radiologists, pathologists, oncologists, everyone involved in lung cancer. But our regions are very different, and I think having the ability to have an Asian conference on lung cancer enables us to focus on the issues that are specific to the Asian and Pacific region. And that's what I'm really grateful for, to getting to know my colleagues and getting to lean into the areas that influence us the most and the challenges that we face and what's unique about us. We know there's much higher rates of lung cancer amongst non-smokers in the Asian region. We've heard from Dr. Ahn how there's very high rates of EGFR mutated lung cancer. And we generally, well, it's quite diverse, but we generally have lower resourcing in the Asia-Pacific region, and we need to face these challenges together. From Australia, where I come from, I'm very proud that we've recently introduced a national lung cancer screening program where any individual with a history of smoking for at least 30 pack years between the ages of 50 and 70 is eligible for a low-dose CT scan to screen for lung cancer every 2 years. And the groundwork and the research that went into this was presented earlier today, for example, by Professor Henry Marshall and Professor Quan Fong, presenting the work on their colleagues that led to the introduction of this screening program. We learnt from other regions within Asia who had experience in lung cancer screening in different settings, including in Japan, where they've had a long history of X-ray screening, and a lot from Taiwan, for example. So I think hopefully other countries from Asia will learn from our experiences in Australia as well. And I was very excited to hear about the possibility of AI technology in several of the talks that we've heard about how they can assist with screening of lung cancer. So I'll pass on now to my colleague, Dr. Van Tu Dao. Would you like to tell us about why we want to go to Spring first? Okay, I beg your pardon. We'll go to Spring next to tell us about why the Asian Conference on Lung Cancer is so important to you and any advances in radiation oncology that you'd like to tell us about.
Thank you, everybody. Thank you, Wendy. I am Fei Ming Spring Kong. Spring is my nickname. Fei Ming is my formal name. So I'm an American board certified radiation oncologist, as you meant, fellow of American Society for Radiation Oncology. Currently practice clinical oncology in University of Hong Kong. What that means, I can not only do the drug, but do the radiation, also do the drug, do both. So I'm currently the director of the Thoracic Oncology Center of Hong Kong U Shenzhen Hospital, and also the president of a global collaborative oncology group. So I served as a co-chair for ACLC last year in Hong Kong, and very honored to be here again, ACLC. And from program standpoint of view, what I would like to emphasize one thing is there is a significant advancement of this year. We focus more on patient-centered multidisciplinary care and also advanced technology that's specifically equipped in with all, the consensus from the co-chairs. As you know, radiation oncology is one of the technology, one of the main treatment, mainstay treatment for unresectable non-small cell lung cancer. But in Asia, however, it's very poorly equipped. So of 48 countries, about half of the country does not even have equipment. And also considering, Lancet Lancet Oncology actually have a survey, and the IAEA have a survey specifically target to low middle income country, and realize that this is an important place to improve a treatment outcome. So if you may recall, actually Asia have 48% of cancer in Asia. However, the ratio of deaths versus new incidence is about 58 actually, 58 in mortality in the death ratio. What that means is the Asia's cancer cure is about 10% worse, than the average. The average is 0.5. So thinking about that part, the Asia effort of International Association for Study of Lung Cancer are very timely, very important for this, and for the Asia people and the Asia lung cancer. And I think for the things what we are doing, and I would like to emphasize the things that I'm personally most passionate about that, and also committed about that is AI technology and a combination of for multidisciplinary care, particularly in combination of immune therapy and precision radiation therapy. As I asked Dr. Ang earlier, for those patients, for those patients fail, what kind of treatment, more specific, more personalized, better tumor control, less toxic, also cheaper, faster. We want all the best for all the best for our patient in Asia, and also financial issue is a big issue in Asia. The immune therapy, a lot of drug target therapy are quite expensive as well. So I think tomorrow I will give AI in decision making, how to use the AI, how to use the knowledge resources intelligently to improve patient treatment outcome. And also another thing I'm going to discuss about will be combination of radiation and immune therapy, powerful targeted local treatment, local target therapy for radiation therapy, with a systemic host-based immune therapy, specifically focused on personalized neoantigen vaccine. And this is, I'm particularly excited about this because our preliminary results are outstanding. As I mentioned we discussed about, we presented the toxicity for personalized neoantigen vaccine, the peptide, really almost zero grade 2 toxicity. That was presented last month in Barcelona, IASLC 2025. So we really have a lot to do. I believe a clinical trial, multi-D, combined therapy, multidisciplinary collaborative, technology integrated clinical study, and something also cost effective, which this year we have that, will be really most important for our Asia people. Thank you all so much for your attention. And also, one last comment I forgot to mention: radiation oncology last year we only have 3%. This year, this morning, the plenary, I see about 30%. So we increased about almost tenfold in radiation therapy. So radiation oncology people are really paying a lot of attention to this multidisciplinary meeting. Thank you very much.
Thank you so much, Dr. Kong. Already have very exciting comment about the conference. And for the AI is the most fastest growth in modern techniques in the cancer, and including in the lung cancer. In this conference, we have a whole section for AI, and then we have a lot of presentation integrate the AI content, and that is mentioned about the AI is very important. The AI at also for the many kind of judgment, and also the decision for the support for diagnosis and the judgment decision. Like Dr. Kong have already radiation, the AI support the Kong for the radiation planning, and Dr. R will already some AI model have help us to refer to recommend the treatment, and the pathologists also have AI to support the diagnosis of molecular, also the molecular morphology, and surgery also have support of AI. In the radiology, is the most important development for the AI. With AI, we already understand the low dose CT scan, the standard of care for the cancer, lung cancer screening. However, AI integrate in the low dose CT scanning is more improve the sensitivity and the specificity, and that is make the more accurate rate for the diagnosis lung cancer. In this conference, we also maybe re-raising the question, may AI how to test X-ray for the better outcome. And before we have avoid the X-ray, but in the Asia country, we have a lot of country of economic system have a low income. In this case, we have less resource for the city low down. In this case, maybe the AI will help us to re-rising the X-ray come for the some institution of the update of the apply the X-ray assisted AI for the for the screening. We thank you. This is some important information about the AI, and in this conference organized by IASLC, like Dr. Cooper already mentioned, is very high-ranking. The association in the world is focused mostly on the lung cancer research, education, and education and treatment. We also are very happy to organize this meeting in the Asia, and it's not only just a conference. That is time we can. Yes, almost. It is time we can. Okay, I'm sorry. So this conference is not only scientific conference. It's the time we can together, stay up together with all scientific to work together to sharing the information, the knowledge and experience in the cancer treatment. Also to make the friendship for joining to advance in the facing the cancer, lung cancer. We would like to really give up for our patient, our community, the valuable support. Thank you so much for joining the conference.
Thank you so much. With lung cancer as a leading cause of death, of cancer-related deaths, we're beholden to do what we can to address that, and I think the Asian Conference on Lung Cancer will go a long way to in our fight against lung cancer. So that concludes our press briefing. Thank you to all of the speakers here today, and we're happy to take any questions if there are any. We don't have any questions online, so thank you very much for your attention. Thank you.
Thank you.